Hey everyone, what's up YouTube? We've got Neil here. Say hi, Neil.
Hello.
We are in front of an elevator shaft doing our YouTube video today. There's a lot of students back there, it's a little noisy. So what we're gonna do is we're gonna talk about fibular head biomechanics, as well as knee special tests, and then we'll get into some treatment, muscle energy with the fibular head. We'll do some counterstrain as well. So first, let's talk about where the fibular head is and what it does. So you can straighten your legs for me. So the fibular head is gonna be on the lateral side. Can I roll this up? Sorry, we gotta roll these up. So fibular head, you're gonna find it, you find like the kneecap here, you go laterally and just down slightly. So his fibular head is right about here, okay? So it's kind of hard to see, but you can really feel it here. So that's gonna be where the fibular head is, okay? Now if you move the ankle into pronation or supination, you're gonna feel some motion at that fibular head. That motion, paired motion, is gonna be with supination, that fibular head goes posterior, and with pronation, that fibular head goes anterior. And you can actually feel that. If you're like sitting for your complex and you're like, I can't remember, you can literally just feel and move your ankle in and out. You can feel that motion, okay? So again, with this fibular head, how we diagnose it, let's say I wanna evaluate his right or left side. I come over to the side. They call it a seesaw motion. So this fibular head and the lateral malleolus, it's the same bone, it's the fibula. If this fibular head goes posteriorly, there'll be some slight anterior deviation on this lateral malleolus. Vice versa, if it goes anteriorly, there'll be some slight posterior deviation. And you can feel that, right, by grasping the fibular head and just find it again. There it is. So mind if I draw on your leg real quick?
Yeah.
So his fibular head is right there, okay? So if we grasp that and the lateral malleolus, spring up, spring down. So I'm doing this, right? I'm checking for motion there, okay? So on this fibular head, there is a slight preference for posterior motion, therefore the fibular head is posterior. And you can even see he's got a slight supination preference going on here, okay? So that makes sense, all right? Now if we do the other side, right, always check everything bilaterally. We're here, fibular head is right here. We're going in that seesaw motion as well. This side feels a little more symmetric. Now, what is not in any textbook, and the way that I like to check, is I will come to the foot of the table here and I will grasp both fibular heads and try to spring down at the same time and spring up towards me at the same time. And I'll close my eyes and feel where is that in space in comparison to each other. So again, I feel like this one is more towards the table, okay, preferring supination, all right? So that is the main biomechanical review of the fibular head. And if we were to treat this with muscle energy, right, if I were treating a posterior fibular head, I flex the knee, I put my thumb behind that landmark. I want to push it anteriorly again. So a lot of my force is there, pushing it forward. My elbow is contacting the table as a fulcrum. I'm bringing his foot into eversion, which is his barrier, with my hand over top, and then I ask him to bring his foot towards the right and relax. And then I add more pressure, barrier again. Maybe I have to shift a little bit and do that again. 3, 2, 1, and relax. And then a third time, do that again. 3, 2, 1, and relax. So I have a lot of pressure on my thumb here, but also pressure resisting his supination here of the foot, okay? That's how you treat a posterior. If I were treating an anterior fibular head, okay, I would have my thumb on the front of that landmark trying to push it backwards, okay? Now it might be easier to have a pillow or something under his knee, but without that, I'm just gonna put my thumb on the front of the fibular head, bring him into supination. Maybe I sit, maybe I hold it this way or this way, and I say, bring your foot, I'm gonna stand so I get more force, bring your foot out towards me. 3, 2, 1, and relax. Some people might use their MCP like that. Or if you got strong thumbs, you can keep your thumb there and then bring it out towards me. 3, 2, and relax. One more time. 3, 2, and relax. Final stretch, okay? And then as always, we reassess here, right? Seesaw motion, okay? So remember too, you can check the talus. If the talus is more anterior on this side, that means he has a supination preference, which fits with a posterior fibular head. So these are all connected, right? The talus, ankle mortise, supination, pronation, fibular head, anterior, posterior. So those are all things they love to ask on boards, okay? So that's how you treat with muscle energy. Now let's talk about the knee, okay? So I'm gonna lower this down, sorry dude. So with the knee joint, you have your medial collateral ligament, lateral collateral ligament, just along the joint lines. You have your patellar tendon in the front. You have your patella, your kneecap. And then you have your meniscus, which is internal, okay? Your pes anserinus, which is just down and medial right here. Remember, SGT, so sartorius gracilis semitendinosus attached here. I'd love to ask that question. You have your tibialis, which is your shin muscle here, your quadriceps up top. So to do special testing for the knee, let's just do it on this side because I'm closer to it. We can test a few things, right? We can test ligament, meniscus. You can test for pain under the patella. So if I were to test, let's just go drawer testing. All right, this is gonna test your ACL and PCL. So if I sit, not a ton on his foot, but just gently enough on his foot, and I bring him towards me, that's your anterior drawer, testing the ACL. If I push, I'm testing the PCL, posterior drawer, okay? If I check a Lockman's, again, I am trying to bring the tibia up towards me while pushing the femur down. That's checking ACL as well, so that's Lockman's. If I'm checking varus valgus stress test, valgus stress, right? I'm trying to push his knee into valgus, that's checking your MCL. If I'm trying to push his knee into varus, pushing out, that's LCL. Any pain with those? Nope. Okay. Now for McMurray's, firmly grasping the tibia, so you can either internally or externally rotate it, okay? Now if I'm internally rotating, I'm also pushing medially, starting in high flexion, rotate, rotate, push, 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 push. That's putting strain on that lateral meniscus, okay? If I do the opposite, so knee flex, externally rotate, push, 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 push while I straighten, that is gonna test the medial meniscus. Is that right? You're gonna do sports med. Okay, he knows, he's double checking me. So push, push, push. You can do it a few times, okay? But again, really gotta internally, externally rotate that tibia with the right direction of pressure on the knee. Next is the bounce home. This is gonna just test meniscus inside of the knee as well. And it's not as specific, but you just say, you know, relax your leg, bounce it. Relax your leg. He was guarding a little bit like that. And if he's like, ooh, or if he's like, ow, that hurt, that means there's inflammation inside of the knee. You can also check for an effusion, which is often present above the knee, okay? You can like push, see if there's some fluid accumulation above. For patellar grind, pushing the kneecap inferiorly and say, squeeze your quad, okay? Any pain there? That's, if he does have pain, that means there's some inflammation under that kneecap. Now, if they don't know how to do that, I just say, all right, try to push the back of your knee into the table. And it does the same thing, it activates the quad, okay? So that is patellar grind. Now, what I'm gonna have you do is flip over. We can do Apley's compression distraction. And this isn't highly specific, but it gives you a little insight. So if I wanna hold onto the femur, push down through the calcaneus, internally, externally rotate. So if he has pain with internal and external rotation, what's up guys? Congratulations. Thank you, sir. And then with this, he might have some meniscal dysfunction going on, inflammation if he has pain with compression. Now with distraction, if I hook my arm under and kind of pull up and rotate, some people want to muscle it up and do this. I just kind of make it easy on myself. Now with that, you might have a ligamentous injury if he has pain with distraction but not compression, okay? Now let's talk about counterstrain, okay? So for our counterstrain points, let's see, in Nicholas, right, everyone's like, what book are you talking about? Well, it's this book. That's the book we teach from. So these guys taught me, they're awesome. All right, so the lateral hamstring is the bicep femoris, okay, and you can find it either mid-belly or towards its insertion, just above the fibular head. So again, this really goes all the way to the fibular head. So bicep femoris, so pain here, No. We go down. Let's say he has pain. He's like, ooh, that's really painful. Okay, so that's his tender point. All right, let's have you lie on your back. And you can do this prone or supine, but probably a little bit easier to do supine. I find that tender point, bring it out. Use my leg to rest his leg on it. So we have abduction, we have external rotation, and a little bit of flexion. So I'm just trying to shorten it there. If he was a 10 out of 10, what would you say it is now?
3.
A 3. Maybe I want more. More flexion, more abduction, more external rotation. What is it now?
0.
0. And we hold that for 90 seconds. Return to neutral, reassess. Oh my God, it's gone, right? Right? It's gone. All right, so that is your biceps femoris, okay? Now if you lie prone again, if you wanted to do it prone, you could do just the same thing, right? So let's say we're here, flexion, abduction. All right, so again, flexion, abduction, external rotation. If we need more, we can go more, okay? All right, so that's lateral hamstring. Now, lateral meniscus is also going to be flexion, abduction with some internal, external rotation, okay? Now, the lateral meniscus point is, again, here is the bicep femoris. You got to go a little more laterally for lateral meniscus. So it's going to be on that lateral joint line. For him, it's going to be right here, and it's very deep. So you're kind of compressing on the outside to get some type of, I would say, extrapolation on what's going on internally. But if that is where his pain is, you can lie on your back, lateral meniscus here. It's kind of right there. So in the book, it shows it right there. So really your LCL, it says meniscus / collateral ligament counterstrain point. Okay, so it's kind of both. Let's bring him abduction flexion about 30, 45 degrees. Let's try external rotation. Does that feel better? What if we internally rotate? Does that feel better or worse?
Better.
This is better? This is better for him. So for him, he likes internal, right? What if I flex him a little more? Is that even better?
About the same.
About the same. Okay. So again, this is your LCL / lateral meniscus point. Return to neutral, reassess. So for the medial hamstring, we can treat this. You can lie prone. Sorry, he's getting his core workout today. So for the medial hamstring, right? This is going to be your semimembranosus. That's going to be along this line, going towards the medial aspect of the knee. Tender here? Yep. Tender here?
This one's worse.
This one's worse? No, this one's worse.
Yeah.
B is worse. All right, I'm always like A, B, A, B. So B is worse, okay? Now if we wanted to treat this prone, it's flexion, internal rotation, and a little bit of adduction here. So here, internal rotation, yeah. Relax your tendon here. There you go. So let's find that, and then here. Is that still tender?
Mm-hmm.
It is?
A little bit.
A little bit. More adduction.
Better, yeah.
This better now?
Mm-hmm.
Okay. So he needs a lot of adduction, internal rotation, and flexion. So medial hamstring. Now for the medial meniscus, you can lie on your back. So you're going to shift your whole body kind of like this. Yeah. So we're going to find it similarly, medial joint line. Is that tender here?
Yeah.
Yeah. So I'm going to slightly flex, going to internally rotate, and I'm going to deliver a little bit of an adduction force through the ankle to adduct here. You see that? Was that tender? Still a little bit.
Yeah.
Better? Okay. Ta-da! That's it. Then we reassess. Yay! I forgot something. We're doing HVLA. Say hi, Marianne.
Hey.
Hi, she's my MA. Hi. So let's say she's got a left anterior radial head. What does this feel like?
Good.
No, be like,
Oh,
ow,
my
ow,
God.
it hurts so bad. See, go look at her face. Ow, ow, ow. Okay, so we're gonna treat it with HVLA, all right? So in the book, right, and Nicholas, do you wanna zoom in on how he does it, right? He's opposite the patient and he pushes down with internal rotation, right? So that looks like this. I'm on the opposite side, heel of the hand on top of the fibular head, rotating, supinating that foot, and the thrust is here. However, I kind of feel uncomfortable because I'm leaning over This I'm slipping. So that is the textbook way, okay? Here's Dr. King's way. So I come to the same side of the patient. I bring her foot into supination with my left hand. On the right hand, I use my MCP on top of that fibular head, like so. So I can make pretty good contact there. And my shoulder is straight above that target, okay? And then my HVLA is straight down, okay? You can also use the heel of your hand here. So again, I have a pillow behind the fibular head to cradle the area and allow for a little bit better of a thrust. So I'm not just thrusting into a table here. So I'm here, supinate, because remember, if this is anterior, I want it to go posteriorly. So you need to supinate here to allow for that mechanic to happen. So I'm here, heel, and straight down, okay? Quick thrust, straight into the table. And then we'll have Marianne flip over on her belly. We're doing a posterior head thrust. Let's say it's on this side here, so her right leg, posterior fibular head. Find it right here. It's more towards me because it's posterior. We use our MCP again to drive it straight that way, which is technically anterior. It's in that anterior plane, okay? So I have my MCP there. That's going to create a fulcrum to drive it this way. So that's blocking here. Now with the foot, remember, if it's posterior, it prefers supination. I want it to go anteriorly. We need to evert. So I have my hand on top, everting the foot. The thrust is unique in that this is blocking, but my thrust is technically kind of healing her glute, like driving the heel towards the glute. Now, I believe in Nicholas they have it where it is, see how he's grasping the ankle, okay? A little bit of that ankle. You can do that. It just creates a lot of torque and you're using a lot of your arm. I come up above on the calcaneus and just externally rotate that way. I just find it a little bit easier. And then the thrust is here and then it's like that, okay? Now you can do it here and do it like that as well. And it's a little bit of both. So it's a little bit of this happening, okay? So that's gonna drive that posterior head anteriorly. So either this way or this way, okay? And then we reassess. How does that feel, Marianne?
Oh my God, so much better.
Yeah, look at her face. She's so happy.